I'm very happy to welcome you to this series of podcasts offered by the Thalassaemia International Federation. As you know, Thalassaemia International Federation, or TIF, is a patient-driven global umbrella organization striving for access to quality care for people with thalassemia in every of this world. And one of the key pillars of TIF's activities is education, which is actually pursued through a variety of different resources targeted to healthcare professionals, patients, and carers, and are all accessible totally free of charge. One of these resources is, of course, this series of podcasts that aim to cover important topics concerning the management of people living with thalassemia, sickle cell disease, or other hemoglobinopathies. And today's podcast is dedicated to the monitoring of iron overload in thalassemia, with a particular focus on the affordable and reliable MRI diagnostics. And to discuss this topic, TIF has invited two prominent figures and key opinion leaders for thalassemia, well known across the globe for their contribution to the field. And it's my great honor and pleasure to welcome, on behalf of Thalassaemia International Federation, Professor John Porter from London and Professor Antonio Bica from Turin. John Porter is a professor of hematology and consultant hematologist at the University College London Hospitals in London, and also the head of the Joint Red Cell Unit at UCL and Whittington Hospitals. And Antonio Bica is a professor of pediatrics at the University of Turin in Italy, and has also served as the Dean of the Medical School at the same university. So welcome to both of you, and without further ado, I will start by asking the first question to Professor Porter. So, Professor Porter, why do you think monitoring iron overload in thalassemia is so critical for the management of these patients?
If I had to give a very short answer, it would be to monitor compliance or adherence to treatment. We can ask the patient how they are doing, and they can give us a precise or deliberately vague answers. And the ferritin is an extremely useful monitor, and we can maybe talk about this in more detail in a few moments. But ferritin alone has its drawbacks or its limitations. So we need other ways of seeing what's happening. In particular, we need to differentiate the iron that's in the liver and in the heart, because they have different treatments and they have different consequences. And MRI has been able to do that. It's been able to give us a much clearer idea about where the iron is, and therefore how we intervene. So that's just a short overview.
Okay, so we'll have the chance to discuss in detail all these issues, and I will ask Professor Bica now. What are the standard methods that we have at this moment to monitor iron overload in thalassemia?
Yeah. The most commonly used method is the serum ferritin. But as Professor Porter said, if it's used as the unique method for monitoring iron overload, it may be in thalassemia syndromes, that is the topic of today. It may underestimate in certain cases or overestimate the level of iron overload. So serum ferritin is very useful because it's easy, it's fast, it can be repeated easily, but it may be fault. Another method in the past, the standard method to see the iron overload in a patient was the liver biopsy. But today we can say that the liver biopsy, if the indication is just to look at the level of iron overload, is not in the field. Because it's invasive, has a lot of limitation too. So the best is to use an MRI approach. And there is nothing else, because there is no other method for iron overload. There is a very simple way that is to look at the transferrin saturation, not for iron overload level, but just in thalassemia syndrome, to have a rough idea of if there is iron free, that is toxic iron, is in or not. So if the level is above 60, 70%, you can be sure that the patient you have in front of you has some iron toxicity. Obviously, also this marker may be confounded if the patient is taking iron chelators. So, but in absence of iron chelators, maybe a rough orientation to start with the patient you have in front of you.
Okay, so this brings us to MRI. So it seems that it is the standard of care now to use MRI to monitor iron overload. And Professor Porter, how does MRI compare to traditional methods in terms of accuracy and reliability? And also, is it a cost-effective method?
Yes, I think that depends on where you're considering the patients being treated. Setting the method up is actually remarkably simple, and you pay a certain amount per scan to the makers of the software. But there are many different softwares available, and we can talk about that because they're not always the same thing. And I very much have favored everybody trying to use the same method, simply because then we can talk in the same currency between thalassemia centers. But it's not cheap, but it's also not that expensive. If you think of the cost compared with the cost of chelation itself, it's not a huge amount of money. And in fact, you only need to do the liver MRI about once a year, usually, unless you're in a very difficult situation. So I don't think it's actually that expensive. Of course, if you're talking about people who've got very little money at all, and the healthcare systems are very stretched, you know, it is difficult. I think you can use the MRI as a starting point, and the direction of travel then with ferritin helps you know if you're going up or down. So you can use it quite sparingly in most cases.
And of course, talking about cost effectiveness, if this method prevents a severe complication of iron overload, which will end up costing a lot of money, it becomes actually a cost-effective approach, right? So what about accuracy and reliability? Are all the MRI methods the same, reliable and accurate?
No, and even if you think you're using the same method, for example, a ferry scan in two different centers in two different countries, if it's not set up properly and it's not calibrated, it's not the same. So you must have some form of external calibration and corroboration. If you do that, then it can be comparable between centers and between countries.
Okay, thank you. So, Professor Piga, can you discuss the placement and the role of MRI in the context of the clinical management of iron overload in thalassemia patients?
Yes, so if it's very important, this key. So if you have in front of you a naive patient at diagnosis, in example, and the age of the patient is something more than 6, 8 years of age, so the MRI is feasible. It's to have a first MRI scan of the patient with a precise and accurate measurement of liver iron concentration and the assessment of the iron in other organs, starting with the heart, is key. Because if you have these in your hand, you can exactly know if your patient is a high risk or not, if the patient needs to start a treatment with iron chelation or not, and also an orientation of the type of chelator or combination to be used. If obviously it's key to have an accurate evaluation. So any MRI system may give an idea of the iron in the liver. That is any company MRI, any magnetic field strength may give an idea. But just to have an idea is not enough. So the basic system to quantify is for any MRI system is the signal intensity ratio. That is just to compare the signal in the organ of interest, let's say the liver, with the muscles on the same section. But this is not enough to guide iron chelation and to monitor iron overload. You need to have a T2 or a T2 star approach. That is the only way to quantify exactly the level. Both methods has been validated. The most validated one is T2. But normally T2 that requires a longer time for acquisition is not good for the heart. So T2 is the best validated and ideal for the liver, but it's not enough if you need the heart. And in thalassemia syndrome, you often or ever need the heart too. So the T2 star approach is the best. Then obviously for monitoring,
okay, in clinical practice.
Sorry?
So yes, go on, continue.
So for monitoring what happened with the treatment, obviously, again, MRI, but just once a year, less than once a year is only for high-risk patient or special treatment. Otherwise, once a year is enough to understand if the iron chelation is effective or not. And the trend of serum ferritin is very nice in an individual patient to see what is happening. So again, for these, you need to test the heart too. Yes, if the patient is on iron chelation, you need to see if the level continue to be normal. That means that a T2 star above 30, or acceptable, that is a T2 star above 20, or there is a change in the level of what you previously tested for. And then obviously the liver. And that's all.
Okay, so in practice, in a patient who is regularly transfused, what is the rates to have the first scan?
When it's possible. That is normally in normal people is said that it's possible to have a patient scan efficiently if the patient is older than 10. In thalassemia syndrome, that are with the patient are used to go to the hospital to have tests. It's possible without any anesthesia to have a good scan even in patients that are 8, 7, 6, 5. It depending on the quality of care in doing the MRI. For less, to have an MRI scan in a very young patient, obviously you need some anesthesia, so is not non-invasive. And we do if there is an important risk, otherwise we avoid that.
And afterwards, once a year would be ideal. But if we have a baseline evaluation and then we follow the trend in serum ferritin, that will give us an idea, at least for the liver iron, right?
Exactly, exactly. So there is no need to repeat a serial MRI, excluding the clinical trials, obviously, but in the clinical practice, there is no need. Even you see that the iron is high, the serum ferritin trend is very high, it's, you know that the problem is very likely the compliance of the patient with your treatment. So it's there is a need to go in depth in the interaction with the patient on compliance, and no need to repeat an MRI. A single MRI is very powerful in having the result on the sheet in front of you with the patient, using that as a fact, a point, the fix, the level of iron overload, where you can, with a non-compliance patient, you can just say, well, the starting point is that the treatment is not daily, the iron chelation is not, because with the dose of the drug you are taking, the MRI is saying that the therapy is not regular. So that is a very good point in putting on the MRI sheet and not on the patient or the healthcare person the problem of what is not working.
Okay, now a tricky question for Professor Porter. So, Professor Porter, what is the trade-off between affordability and reliability for the MRI iron assessment?
It is a difficult question, but actually it's simple. If the test is not reliable, you shouldn't waste money doing it.
Yeah.
There's absolutely no point in doing it. So unless you've got a technique that's been externally validated and is accepted internationally, then you're wasting your money. And I feel that very strongly. I agree with everything that Antonio said. I do have a nuance or a caveat, which I wanted to talk about. And that is when you have a high ferritin, let's say it starts at around 3,500 or 4,000, and you institute a new chelation therapy, you may be doing good, but you may not be certain that that's happening just from monitoring the ferritin. So when the ferritin is very high, it's fairly insensitive to changes in liver iron concentration. So let's say you put somebody on some kind of combination regime and the ferritin has stayed exactly the same for a year or 6 months. Mm-hmm. Then the MRI has an additional usage to tell you the direction of travel, because that will pick up the direction of travel when the ferritin may not, particularly at high levels. I don't know whether Antonio would agree on that.
Yes, yes, absolutely. And this is more and more true for the liver level of iron load. For the cardiac level of iron load, we must prepare the patient to the fact that even with daily effective, perfect prescription and taking of iron chelation, the lowering of cardiac iron will be low. So, and there is a need to have lowering consistently the level of liver iron to have an important effect on cardiac iron loading. So to prepare the patient before doing the MRI test is very important. Otherwise, the patient will say, oh, but doctor, your prescription is not effective enough. So, but if we explain very well and prepare the patient, is possible to have very good results.